All right, hi all. I'm Michael Morella, a managing editor for events at US News and World Report, and thanks for joining us for today's conversation. We are broadcasting on Zoom and on Facebook Live, and we're making video of today's discussion available after the fact. So be sure to tune in to our US News YouTube channel or usnews.com/events for more information after we conclude. This has been an incredibly challenging and historic year for all Americans, and in particular for the healthcare professionals and scientists on the front lines of battling the coronavirus pandemic. In recognition of their efforts, US News has been publishing a special series called Hospital Heroes, where we've featured everyone from librarians turned contact tracers to ER doctors, ICU nurses, and those treating the dual crises of COVID-19 and systemic racism. Recently, we also profiled today's guest, Anthony Fauci, the nation's top infectious disease doctor, and perhaps the country's single most authoritative voice on COVID-19. Dr. Fauci is director of the National Institute of Allergy and Infectious Diseases, a post he's held for more than 3 decades at the National Institutes of Health. He's been a key advisor to 6 presidents, health officials, and the public, and is a pioneering HIV/AIDS researcher, as well as the recipient of the Presidential Medal of Freedom, the National Medal of Science, and numerous other awards. We are truly honored to have him with us today, Dr. Tony Fauci. Now I'll turn the microphone over to Brian Kelly, Editorial Director and Executive Vice President of US News. Take it away, Brian.
Thanks, Michael. Welcome, Dr. Fauci. Thank you so much for taking time with us today. Big news day in the Tony Fauci world. It's always a big news day in the Tony Fauci world, but I see that you have achieved lifetime success as being on a Topps baseball card today. Could you give me your reaction to that?
Well, that's certainly a bit humbling at best, a little surreal. I'm trying to deeply get involved in what we're all focusing on, and baseball cards come out. It's you know, who could have predicted this? I try to not let it distract me and focus on the things that are important right now, which is getting this pandemic under control.
Well, communication is obviously something you have put a lot of time into. It's an important part of epidemiology. You stepped out there and threw the first pitch at Nats Park, one of your beloved teams. But that pitch, by the way, the card caught you at a very good moment, but I think it kind of went a little awry. What were you trying for, a split-fingered curveball there? What was your thought?
Well, the story was I had practiced a couple of nights before, and I paced out what I thought was 60 feet, which is the distance from the mound to home plate. I miscalculated. I think I was around 40 feet. So I was throwing very well. It looked like I was really good to go. I kind of threw my arm out. I practiced so much. But when I got out to the mound and I looked at Sean Doolittle, he looked like he was about 500 feet away. So rather than just throw it the way I'd been practicing, I decided I would really whip it to him. The only trouble is I threw a line drive ground ball to first base instead of to the catcher. It was kind of embarrassing, but it was still all fun. It was all good.
We've all been there. So on to your day job. Let me ask if I can get you to take a little bit of a 30,000-foot perspective here and ask you, 4 months into this pandemic, what have we learned about this disease?
Yeah, we've learned that it is extraordinary. It's not to be underestimated. In many respects, there were things about it that we still are learning, literally on a week-by-week basis. It is the most unusual virus. It has a spectacularly efficient capability of spreading from human to human, hence the pandemic nature of where we are right now. It is so broad in its manifestations. I've been dealing with viruses, as you mentioned, for now 40 years, for multiple different outbreaks, from AIDS to Ebola to Zika to pandemic flu. I've never seen anything that has such a broad range of manifestations, from a certain percentage of people, sometimes up to 40%, who have no symptoms whatsoever, to those who have minor symptoms, moderate, severe, some get hospitalized, some require intensive care, and some die. And you go from nothing to death. It's very, very unusual. And I think that's the reason why some people underestimate this particular outbreak and the potential seriousness of this disease. What we're learning now, just recently, is that individuals who get sick, particularly those who are in bed for weeks at a time, or those who get hospitalized, when they clear the virus and are so-called well, many of them are not well. They have lingering symptoms that go on for weeks to months of fatigues, aches. You could have heart problems, neurological problems. So there's a really tough. The overwhelming majority of the people get better and do fine. Like I said, 40% at least have no symptoms at all. But the ones who do get sick, some of them go on to very serious consequences and die, but some have lingering symptoms. And again, weeks go by, months go by, we learn more and more about this very formidable virus.
The transmission issue, I mean, as you suggested, it spreads remarkably. Why is that? What have we learned about why it is able to move from person to person so efficiently?
Well, because the level of virus that's in the nasopharynx of people is very, very high level. So when people even speak, forgetting about coughing and sneezing, which we know transmits droplets, but it's very clear when people do something as easy as just speaking, there is bits of virus can come out. And you can measure that through certain types of light refraction, which is the reason why, I'm sure we'll get to this in a bit, why it's so important to have universal wearing of masks and maintaining distance of 6 feet or more, avoiding crowds, the kind of fundamental things that we need to do to really prevent ourselves from getting infected and to prevent us, who might be infected and don't even know it, to prevent us from infecting someone else.
I mean, that's something we've learned more about fairly recently, right? The idea of aerosolized particles and that somehow the droplets can be very small. They don't just drop to the ground. The early days, we weren't as worried about that. Is that correct?
Well, that's right. And again, one of the things that this outbreak has taught us, Brian, is humility and realizing that it is an evolving process. And what you assume based on the data that you know on one day, you have to be flexible enough to change your thinking as more data and more scientific evidence comes in. You can't be fixed on something that you thought was true or you thought was a certain way a few months ago. And things we're learning right now is just what you said. There likely is much more of a contribution of what we call aerosolized transmission than what we thought. And that means that instead of something just going down, it kind of can linger around for a while, which makes it all the more problematic of why we say outdoor functions are much, much safer than indoor functions. Because when you get indoor, if you have aerosol that can hang around, the recirculation of the air by whatever means can continue to let this expose people. And there are good examples, for example, of situations in restaurants. One very, very notable example was a restaurant in China where people at tables reasonably far away from what you would think a respiratory droplet would fall. Somehow the recirculation got several people in that restaurant infected. Same thing with a choir, where people were in a choir singing together indoors, and many people there distant from the person who was infected also got infected. Those are called super spreading events, not necessarily a super spreading person, but a particular event, almost always indoor when you see that. That's the reason why when we talk about the kinds of things we need to do, I've always said, and we're trying to emphasize it more and more, 5 or 6 fundamental things: universal proper wearing of a mask, avoiding crowds, distance, physical, 6 feet at least, stay away from places like bars. And in fact, some places are actually closing bars, not every place, but just stay away from those kinds of places. outdoor always better than indoor, and hand hygiene. Wash your hands as frequently as you can. Those 6 things, Brian, can go a long way to turning around that curve of surging that we saw and even prevent surging from occurring in some other states.
And you've been clear on those pretty consistently here, but not to the extent of shutting down businesses and other institutions. Is that correct? Is there sort of a line that you've drawn where we were more extreme several months ago and we have a different protocol right now?
Well, Brian, when we were trying to open, and still are, by the way, trying to open up the country again, get the economy back, get people back to work, we have to continue to try and do that. We set some guidelines for opening America again. They were well thought out. I think we know now, looking back, some states did not abide as well by those guidelines. Some states tried, but the people in the states were reluctant. They did an all or none phenomenon. They were cooped up and shut down. And then instead of opening up in a prudent, gradual, step-by-step way, they went to crowds, they went to bars, they had not wearing their masks. That led to the surging now. So people ask, does that mean we should completely shut down again? I don't think that's necessary at this point. You want to keep an open mind. It may come to that. I hope not. I doubt it. What I think we can do is those states and cities that were opening up maybe in a way that was a little bit too vigorous and a little bit too aggressive should put a pause, time out, maybe move back a little bit, and then reassess, reset, and say, okay, now we're going to continue to try and reopen America, but let's really take a look at those guidelines and not jump over the checkpoints and do it in a way that's careful and prudent. If we do that and abide by those 5 or 6 principles that I mentioned, I believe that we can turn this around and we can get good control over what's going on out there.
There's obviously been another surge of cases and some increase in the death, both the hospitalizations and the death rate. But is it the case that, let's say, what have you learned about the fatality rate of this disease? Has it declined as we've seen more cases?
Well, you know, a fatality rate, Brian, is an elusive number because of the lack of precise determination of what the denominator is. You know, there are many people out there who are infected with no symptoms at all, and we don't know they're infected and they don't know they're infected. So the death rate is, you know, the number of people die over the number of people who are infected. If you don't know the totality of the number of people who are infected, then the death rate is going to really vary. Right now, you know, in some places people say it's about 1%. In some places when you get particularly, you know, elderly people and people who have underlying conditions who get seriously ill, the death rate can be substantial.
Right.
But in general, the country in general, it's relatively low.
Right. But 1% is still a significant death rate, I guess, when we compare it to the flu, for instance, which is what everyone seems to.
You know, remember, death rate versus number of deaths. This is a serious issue with deaths. We've lost 154,000 people in this country, and we're still in the middle of this. So you may have a low death rate, but when you have a large number of people getting infected, that counts.
Yeah, yeah, depends on the numbers. Just on the reopening questions, question on so many people's mind. We've written about it. We get it all the time. Is the schools question. I know you've spoken to that. What's your guidance today on how should schools treat this?
Well, what I start off, Brian, is a fundamental principle that as a default point, we should try as best as we possibly can to get the children back to school for a couple of important reasons. One, the psychological welfare of the children, the fact that many children rely on schools for nutrition, for breakfast, for healthy lunches. Also, there's the unintended downstream ripple effects on families where parents may have to interrupt work to take care of the children at home. creates a big issue. So we should try to do that. There's a big however there. And the however is we must not compromise the health, the safety, and the welfare of the children, of the teachers, and secondarily of their parents who they may spread it to. So what do? We live in a big country. There's a great deal of variability in the level of virus in one part of the country versus another. We must be flexible and open-minded, and one size does not fit all. There may be counties and cities where the infection rate is so low that you can go back to school with impunity and not worry about things. Yet there are parts of the country where the infection rate is such that you may need to modify what you do. Have a hybrid, have some days on, some days off, morning, afternoon, masks, or what have you. And then there are other areas of the country where the infection prevalence and rate of new infection is so high that you really have to say it is not a good idea to bring the kids back to school. You've just got to be flexible depending upon the level of infection where you're located.
Let me ask you about vaccines and the progress on that. I mean, there's a tremendous amount of work you and your colleagues are doing at NIH. We're doing some things, I think, that are unprecedented in terms of pushing the curve on speed and basically making vaccines that we don't even know are going to work right now. Walk us through where you feel we are with several of these vaccines. We can go deep here. There's a couple of types of them. I'd like you to explain what you think of, you know, which ones are the most promising and how quickly do we think we're going to have one that I'm going to get? And when you get one, can you put aside a vial for me?
Okay, Brian, that's a bunch of questions, but I think we can answer them pretty concisely. First of all, we're in a good place with regard to vaccine. When I say we mean we as a country, but even the world, because we're not the only ones that are making vaccines. There are a group of candidates, 5 or 6 or more, that the federal government is involved directly or indirectly with supporting multiple components of the process of developing a vaccine. We've been able to move extremely quickly without sacrificing any safety issues, without cutting corners, and certainly without compromising scientific integrity. And the reason is we have the technology now of using different vaccine platforms, which means different types of vaccines that you could move very quickly. One example is that when we saw the sequence put on a public database in January, within days, we began developing one of the multiple candidates. Very quickly thereafter, 62 days, which is unprecedented, we went into a phase 1 trial. Then phase 2, last week, 2 vaccine candidates went into phase 3 trial. Phase 3 asked the question, does it work in the real world of infections in community? And 2, further information on safety. The reason I feel cautiously optimistic about vaccine is that the early studies, both in an animal, but importantly, in the phase 1 study for safety, we found that the vaccine induced in the volunteers a level of neutralizing antibody, which is the gold standard of predictability of efficacy. It induced a level of neutralizing antibodies that was comparable to, if not even better, than what natural infection induces that you see in convalescent plasma. That's good news. There's never a guarantee that you're going to get a successful, effective vaccine, but that's a pretty good sign. We have vaccines now that started in phase 3. Other candidates will start a month or 2 or 3 from now. It takes about 3 months to get enough people into the study. Then you start looking for results. So we would hope that by the end of this calendar year, we will know if we have a safe and effective vaccine. One other thing that's important in this dialogue, and that is that at risk of finances, not at risk of safety, not at risk of scientific integrity, the government has invested hundreds of millions, if not billions of dollars, to make vaccine doses before you even know that the vaccine works. Why is that important? It's referred to as proceeding at risk. That means that if the vaccine works, you've saved a bunch of months rather than waiting until it works and then making the vaccine. If the vaccine doesn't work, you lost a lot of money. But we feel this is serious enough that it's worth the financial risk, which means by the time we get into 2021, we should have vaccine that will start to be available to people towards the end of 2020, the beginning of 2021. As we get well into 2021, there will be hundreds of millions of doses available. So if that's the case, you and I, when they're available, I would recommend we both get vaccinated. Not ready yet, but when it is, I think it's a good idea.
Yeah, I think I saw someplace the Oxford University one, which was one of the first ones out of the box. They were talking with AstraZeneca. They talked about they may be injecting people in beyond the trial in as early as September.
Yeah.
Is there anything to that?
That is pretty quick. I'm a little bit skeptical about having a vaccine that you know is safe and effective in September. Certainly possible. I predict somewhere, and many of my colleagues, that even going quickly, it depends, Brian, if you want to be certain of the safety and the efficacy. I mean, you've heard the Russians and the Chinese saying they're already vaccinating people. Question is, you got to test the vaccine if you want to be sure that it's safe and effective. And I think we owe it to the American public that when we give them a vaccine, we can say with a degree of confidence that this vaccine is safe and that it's effective. You may be able to get there before November, December, which is when I would predict. I hope we do. And if we do, that would be wonderful. But that would be a bit of a stretch to get it as early as September.
Do you have a favorite? Is there a Washington Nationals of vaccines on your list?
No, Brian, there's not. I think it's so premature to make any prediction which one will be better or worse than the other, or which one might be more suited to one subpopulation of people versus another. I have hopes, and I'm wishing good luck on every one of the candidates, because what we'd like to see is more than one being shown to be safe and effective and approved.
Interesting. Different vaccines for different types of people.
Right.
Yeah. Let me ask you about the therapeutic, the treatment side of this now. I mean, frontline doctors were struggling mightily in March and trying to understand what this disease was. As you say, we're still trying to understand it. But they seem to have made a lot of progress. If I am your patient and I come down with early stage COVID, how are you going to treat me?
Well, that's a good point, Brian, because we don't have a lot yet. And I underscore yet, because I think we're rapidly getting there. We don't have a lot yet for early infection. What we do know that there have been 2 therapeutics that have been shown in a randomized placebo-controlled trial to be effective. One, dexamethasone, in a study in the UK for people on ventilators and those who require oxygen, but not in early disease, dramatically and significantly diminished the death rate. Another drug, remdesivir, when given to people in the hospital requiring oxygen, those individuals had a diminution significant in the time to recovery. So that's for advanced disease. What we are now testing, literally as we speak, they're going into trial this week. Some monoclonal antibodies have already been in trial. Others are going into trial for outpatients and for inpatients this week. What's a monoclonal antibody? A monoclonal antibody is a product that the body naturally makes, that you can take the cells out of the body, clone them, and make an unlimited amount of this protective protein called an antibody and infuse it into people. We're aiming for that to be early in disease, to prevent people from having to go to the hospital. Then there's studying convalescent plasma, getting people who recovered, take their plasma, give it to an uninfected person, or make hyperimmune globulin and then give it to a person. So there's a lot of irons in the fire now, Brian, for early treatment, as well as even more for late treatment. Some of the complications of hypercoagulability, doing things like trying to prevent that aberrant coagulation state. A lot of things going on.
So you feel that, aside from the vaccine question, that, you know, if that at some point, again, this year, we will have a pretty good handle on how to treat people who do become infected.
Yeah, what I would like to see, and I think it's a feasible aspirational goal, is by the time we get into the fall, namely September or so, that we will have more than one therapy that could be used early in the course of the disease to prevent people from going on to serious consequences.
So how about you? How is the only doctor in America on a Topps baseball card keeping his health and his sanity besides throwing your arm out?
Well, this is a very unusual time, Brian. This is such an important thing. I mean, obviously, I'm exhausted, but so are, you know, there's a lot worse things that can happen to you than to be exhausted. I always kid around, I think, with my friends saying, I'm running on fumes, but the fumes are so thick that I'm able to go at a really rapid pace. There's too much at stake here. I'm doing fine. I mean, I'll worry about resting when this is over, not now.
All right. And I know Christine is taking care of you, so that's important.
She's good. I mean, she's the one that saves me from being too foolish with myself.
Let me ask you the last question. We had the pleasure of interviewing Francis Collins a few weeks ago, and I asked him, and I will ask you, a lot of our audience is healthcare professionals, you know, coming out of our best hospitals and our community health rankings and things like that. So we get a lot of folks who are running institutions or on the front lines. What's your advice to them as we get into this sort of, you know, next phase of this pandemic?
Well, first of all, before I give advice, I just want to thank them. I mean, there's nothing more heroic than our frontline workers who are out there every single day, putting themselves at risk, taking care of people that need to be taken care of. So first, thank you. That's what I say. But secondly, this is not over yet. It will end, guarantee. We will get back to normal. But we have significant amount ahead of us that we need to address. Right now in this country, as you know, we never came down to a good baseline. We had that peak, and then we came down to about 20,000 infections a day. Then with the resurgence, it went up to 50, 60, even 70. It's coming back down again. We're starting to see the curve starting to come back down. What we need to do is to keep it going down. And in those states, and there are several of them, usually yellow-coded states where they're not doing badly, but they're just at that point where they're risky, to prevent them from going up in a surge. That's a lot that we're going to be facing in the next weeks to months. So for those of the group out on the front line, thank you for what you're doing, but be prepared because there's a lot of work ahead.
Great. Thank you. Dr. Anthony Fauci, we appreciate your valuable time. Please stay healthy, and please put aside one of those vaccine vials for me when you get one.
Will do. Thank you, Brian. I appreciate you having me on this. Thank you very much.